I think you're. I think you're still muted.
All right, can you hear me now? All right, thank you. Okay, thanks for the invite. So let's go ahead and get started. Um, so I'm going to talk about pediatric acquired demyelinating syndromes, and I have nothing to disclose. So talking about pediatric neuroimmune disorders first, before we start talking about the more specific acquired demyelinating syndromes, I just wanted to touch base briefly on the broader spectrum of neuroimmune disorders. These are a heterogeneous group of disorders, and they can have pretty diverse clinical presentation, very complex pathophysiology and underlying autoimmune mechanism. They can be antibody-mediated, immune cell-mediated, associated with infection, neoplasm, or underlying genetically driven mechanisms to create immune-mediated disease. And it's a really large group of disorders, but at its core, it basically manifests with an inflammatory reaction in the central nervous system. So with that in mind, we are going to start today's talk, and our educational objective is basically to discuss these 4 syndromes. And the way we're going to do it is we're going to talk about what is it, what does it look like on imaging, and what's new, if anything relevant, and we're going to discuss that as well. So starting off with acute disseminated encephalomyelitis, or ADEM. So ADEM, pediatric ADEM, is defined as per the 2013 International Study Group as a more heterogeneous syndrome that comprises of a first polyfocal clinical CNS event with presumed inflammatory demyelinating cause, encephalopathy that can be subtle but is not explained by fever, an abnormal brain MRI during the acute, and acute is defined as a 3-month phase. And beyond the acute phase, there are no new clinical and MRI findings. So this terminology, it's best to clarify that ADEM is a heterogeneous entity, best viewed as a syndrome rather than a specific disorder. So on imaging, there can be diffuse, poorly demarcated, pretty large, fluffy-looking fluffy-looking cerebral white matter changes. T1 hyperintense lesions are not typical. There can be involvement of the deep gray matter, and longitudinally extensive transverse myelitis can be seen, which is basically defined as involvement of more than 3 vertebral segments. So here's a case of ADEM with, you can see, bilateral asymmetric patchy white matter involvement. There is involvement of the deep gray basal ganglia and the thalami, and a longitudinally extensive transverse myelitis. Now, ADEM, like as in what's new, is the most prevalent clinical syndrome at presentation in children with MOG-associated antibody disease. In fact, MOG-IgG are detected in about 50% of pediatric patients who present with ADEM, and these kids are usually less than 10 years. So rightfully, it's a diagnosis of exclusion. And I think many of us would have encountered cases like this, where this was a case that a kid presented before MOG antibody testing was available. And you could see bilateral, like asymmetric, patchy, cortical, subcortical white matter changes, involvement of the thalami bilaterally, and cortical restricted diffusion. So it kind of looks like, is it ADEM, is it viral encephalitis? Now the kid came back with a seizure, and at this time, MOG testing is available freely, and when tested, turned out to be positive for MOG. And so this basically is MOGAD. So that is a good case with which we can enter into our next segment, which is basically we're going to do a little bit of a deep dive on MOG antibody-associated disorders. So just starting a bit on the history, MOG has been known to us for a very long time in terms of animal studies, where this 1986 paper talked about the M2 autoantigen when they did experimental studies in animals for allergic and autoimmune encephalitis. And then in 2007, MOG-specific autoantibodies were identified in a subset of ADEM. And then there's been a lot of literature. And very recently, specific criteria has been proposed for diagnosing and defining MOG, and that too in 2023, so it's really recent. So here we are going to talk a little bit about why it's so interesting. One, you see it more commonly in pediatrics. When you think about NMO spectrum or multiple sclerosis, they manifest a lot less commonly in pediatrics compared to MOG antibody-associated disorders. It's new, it's evolving, and even the proposed criteria is so recent. So I think it really, it's very interesting. There's so much to learn about this. So it's really nice to do a deep dive on MOGAD. So what is it? It is an autoimmune demyelinating disease. You have presence of IgG antibodies to myelin oligodendrocyte glycoprotein, which is MOG, which is a marker for oligodendrocyte maturation and myelin compaction. So basically, it's an oligodendrocytopathy. And as I said, it's more common in children than MS or NMOSD. So I'm quoting a little article here just to show you that, just compare, when you compare with the percentages that we'll discuss when we go to those next subsets, there's a much higher prevalence in pediatrics. We don't see much of a gender or a racial predilection here, and MOG can be either monophasic or it can present as a relapsing disease. And the relapse rates, they're pretty variable in varying reports, like at least 17 to 20%, but there are some reports where they've even reported a very high percentage of cases can relapse. So I think it depends on the sample. Interestingly, children, the first manifestation is typically either ADEM, most commonly with or without optic neuritis. While in adult population, optic neuritis is the most common onset feature. So here's a graph that shows the kids. It's almost a 176 cohort. It's a pretty big cohort. And you can see that ADEM lesions are close to 50%, optic neuritis almost like between 35 to 40%. While in the adult population, predominantly, it's optic neuritis. So, let's talk about this criteria because it's so new. So this international MOGAD criteria, which basically, talks about three things. One is a core clinical demyelinating event, which can either be optic neuritis, myelitis, ADEM, a cerebral, like a mono or a polyfocal, or a brainstem or a cerebellar syndrome, a cerebral cortical encephalitis with or without seizures as a core clinical presenting feature. And then you test for MOG IgG antibody. And if it's a clear positive, then in the absence of a better explanation, you don't need additional supporting evidence. But if the MOG IgG test is a low positive, or it's positive, but it doesn't have a filter report, or it's negative, but it's positive just in the CSF, which is not the best thing because MOG is extrathecally produced. So then you have to do two things. You test, make sure that the equipotent P4 IgG is negative, and they need one or more supporting clinical or MRI features, which would include optic neuritis, which has been, per the criteria, in MOG antibody-associated disorders, tends to be bilateral simultaneous clinical involvement, longitudinally extensive, which means it involves more than 50% of the optic nerve length. There is often perineural optic sheath enhancement or optic perineuritis, and often optic disc edema. When we come to myelitis, the three components that are mentioned in the criteria is longitudinally extensive transverse myelitis, a central cord lesion, or an 8 sign, which basically when it predominantly involves only the gray matter, central gray matter, and presence of a lesion in the conus. So if it involves the conus, that sort of puts MOG higher up. And when it comes, in brainstem or cerebral syndrome, it's multiple ill-defined T2 hyperintense, supra and often infratentorial white matter lesions, deep gray involvement, ill-defined T2 hyperintensity involving the pons, middle cerebral peduncular medulla, and cortical lesions with or without lesional and overlying meningeal enhancement. So we'll just take a look at it. And this was proposed in 2023. So it's really, just recent. And any criteria, it's always at the exclusion of a better diagnosis. So that's a core criteria too. So when we look at brain imaging patterns, keeping the criteria in mind, you can sort of think of this as, either as ADEM or there's a cortical encephalitis pattern where you have these T2 hyperintense cortical lesions that show reduced diffusion. There is sort of a meningeal pattern with leptomeningeal enhancement that you can see either with white matter change or in isolation or with cortical encephalitis. And the presence of meningeal enhancement can be a pretty helpful clue for MOGAD. Rarely, in much younger kids, you can see a leukodystrophy-like pattern where there is white matter involvement with progressive damage. But this is very, less commonly seen. So in the ADEM pattern, it's going to, look like a typical ADEM disease. So you have these bilateral supratentorial subcortical deep white matter involvement, deep gray cerebellum brainstem, typically fluffy, polydemarcated, kind of large T2 hyperintense lesions. So I'm going to take you through some cases, and all of these are proven cases of MOG, antibody-associated disorder. So here's a kid presenting with facial weakness and asymmetry and worsening ataxia, where you have this asymmetric patchy white matter, involvement. They're pretty large, fluffy, not very well demarcated. There's involvement of the deep gray. There's involvement of the brainstem and the cerebellar hemispheres. Now here's another case of a child with a viral, prodrome, and then comes in with headache. And here you see that there's predominantly gray matter involvement, bilateral thalami and brainstem involvement. You can see the cerebral peduncle, the pons, and the middle cerebral peduncle. So there can be some, variations in how they present and how they look on imaging. Going on to another imaging pattern of cortical encephalitis, where we're looking at the cortex to see for lesions that are bright on T2 and they may or may not restrict. Very commonly, these can present with seizures. That might be the first clinical presentation. And there is a term called flames, which is nothing but flare hyperintense lesions in anti-MOG encephalitis with seizures. And this can be mistaken as, is it a viral etiology, a viral encephalitis, or other differentials? So it's just good to keep in mind that MOG can also present as cortical encephalitis. And here's a young kid that presented with seizures, where you kind of see a typical, very cortical-based increased T2 signal with reduced diffusion and some deep gray involvement here. This kid tested positive for MOG IgG antibody. Here's another kid presenting with altered mental status and intractable epilepsy, where you can kind of see a very predominant cortical involvement and also almost symmetric deep gray involvement of the bilateral basal ganglia and medial thalami. And this kid also was positive for MOG IgG. So in other presentations, sometimes they can present with a lot of meningeal enhancement, like we talked about. And this can be mistaken as an infectious etiology. So you have to look at the clinical setting, of course, but just keeping in mind. So here's a 10-year-old boy who presents with a lot of vision loss, bilateral papilledema. And here you have, we didn't see any white matter lesions, but you have these isolated like leptomeningeal enhancement. Pretty easy to pick up on these 3D post-contrast flare cube images. It's subtle. This kid did have aseptic meningitis and tested positive for MOG. So things to sort of add on to what we saw is that T1 hypointense lesions are pretty uncommon. The appearance of brainstem lesions does not reliably distinguish patients with MOG IgG from those with equiporin 4 IgG seropositive NMOSD. And in MOG, typically, there'll be almost complete or near complete clinical and radiologic resolution. So, these lesions keep persisting even after treatment after a long time, then that's kind of atypical for MOG. When we go further into optic nerve imaging, like we talked about bilateral, longitudinally extensive optic neuritis, this is pretty common at onset for both pediatric and adult populations, but relapses can be unilateral. And then sometimes there can be multiple relapses. And there's a term again used called CREON, which is basically chronic relapsing inflammatory optic neuropathy. In the setting of MOG, it is referring to recurrent optic neuritis. There's also often inflammation of the optic nerve sheath, or called as optic perineuritis, and optic disc edema. So this is the same kid with, in the brain, just had leptomeningeal enhancement. But also when you look at the orbits, there is this longitudinally extensive optic neuritis. You can see this enhancement of bilateral optic nerves involving the entire length of the intraorbital optic nerve segment and a little bit of the intracanaliculaar portion. And also typically these spare the optic chiasm and the optic tract. So you can see that there is no enhancement in the optic chiasms. Okay. And here's another kid with vision changes, eye pain and vomiting for over a week. And here we see again a bilateral longitudinally extensive optic neuritis. And you can see, how this optic nerve sheath is enhancing. So you can see this thin, rim of enhancement that is surrounding the optic nerve, outside the subarachnoid space of the optic nerve sheath. So it's called a donut sign. And you see that more commonly in MOG when compared to the other two. So that's something to take back. So when we look next at the spine, again, longitudinally extensive transverse myelitis. So that's seen in more than 60% of the patients, where it's defined as involvement of 3 or more vertebral segments in length. Look at the conus and look for more predominant central located lesions, either involving both the gray or the white matter, or just predominantly involving the gray matter, which is referred to as the 8 sign. Again, MOG is not the only disease that can have a preferential involvement of the gray matter. You can see it in acute flaccid myelitis. So you need to take in account the clinical context, but it's always good to remember that MOG can look like that, so they can just test it. Okay, so here's a case of a child with difficulty with ambulation, urinary retention, back pain, fatigue, and then has this extensive longitudinal, the extensive transverse myelitis involving the entire cord from cervical to up to the conus. And on the cross section, you can see the 8 sign with that preferential central cord gray matter involvement. Okay. So another couple of take-homes is like they can have clinically silent lesions, like if you have disease involving brain or optic, like you want to make sure you're imaging brain, orbits, and the spine in all cases, and you in all of these demyelinating diseases, right? And then, as we talked about meningeal enhancement in the brain, so similarly, contrast enhancement can be seen in the spine with about 50% of the patients with transverse myelitis and MOG-IgG positive can have quad equine PL enhancement. So, give contrast to your protocols, of course. So going on to our next subset of neuromyelitis optica spectrum disorder. So this is also an autoimmune demyelinating disorder. And the antigen here is the aquaporin P4 water channel. And this was, figured out in like 2004. And in 2007, the NMO spectrum disorder, the term came into play. Like compared to MOG, which is more of an oligodendrocytopathy, NMOSD is more of an astrocytopathy. There's more profound like axonal loss and insult. Now, pediatric onset NMOSD before the age of 18 years, like all the pediatric onset is before the age of 18 years, right? So that accounts for about 3 to 5% of all NMO spectrum disorders. And usually in pediatrics, they'll present with optic neuritis or longitudinally extensive transverse myelitis. Now, while MOG can be both monophasic and relapsing, these are typically relapsing in a great percentage of cases. So here is the 2015 criteria, just to kind of, where clinically, the core clinical event should involve either it's an acute optic neuritis, an acute myelitis, an area postrema syndrome, an acute brain stem syndrome, like, presenting with symptomatic narcolepsy or an acute diencephalic clinical syndrome with NMOSD typical diencephalic MRI symptomatic cerebral syndrome and typical brain lesions. And then again, you test it, it's positive, that's great. You don't have any other better alternate diagnosis. But if it's negative, or if you don't have the aquaporin P4 IgG for whatever reason, then you need to look at 2 other things. That is, you need either a minimum of 2 core clinical, and at least one of them being optic neuritis, longitudinally extensive transverse myelitis, or area postrema syndrome, and then look at MR findings. So MR findings would include optic neuritis, but here it's more posterior. It's also longitudinally extensive, but it involves, the optic chiasm far more commonly. again, longitudinally extensive transverse myelitis. And in the brain, you're looking at area postrema syndrome, where you want to look at lesions in the dorsal medulla, or any sort of acute brainstem syndrome, or typical periependymal lesions. So this is per the criteria that's on the literature from 2015. So we can look at some patterns here. And brain lesions are more, they're usually more common in children, compared to adults, and they're usually pretty large and more than 2 centimeters in size. These are often along the equipotent P4 distribution, which I'll show you a picture in the next slide, but they're typically periependymal. They're along the circumventricular organs and the subfield regions, brainstem, the optic chiasm. So you can kind of remember why it's more posterior, because of the distribution of the equipotent P4 antigen. Your hypothalamus, corpus callosum, the typical distribution of the diencephalic, hypothalamic, and area postrema lesions, that should have, you should, think about NMOSD when you see something that looks very typical, but it may not always be typical. And then enhancement can also be seen in a decent number of cases. The enhancement patterns are usually like cloud-like, or they can be a thin periependymal enhancement. Leptomeningeal enhancement is much less common when you think about MOG and the different patterns of enhancement. So here in red is marked your normal distribution for the equipotent P4 antigen. So it goes, it's sort of just following that red line. It's along that periependymal surface of the corpus callosum, hypothalamus, the periaqueductal gray, the area postrema, and the central canal of the spinal cord, the periependymal surface of the lateral ventricles, third ventricle, optic chiasm, periaqueductal gray, and then along that fourth ventricle and dorsal medulla. And then correspondingly, from this article, you have these really nice distribution of cases. So this is a very typical case. But sometimes you may see other imaging patterns too, which have been reported in literature very nicely. The corpus callosal involvement acutely, it can be pretty edematous with a sort of marbled or heterogeneous hyperintense T2 signal. And this is the term used here is like an arch bridge appearance. So I can show you a case of that. Interestingly, corticospinal tract involvement has been noted in a 23 to 44% of NMOSD patients, even though that's really not a region with very high equipotent P4 expression. Also, you can have sometimes, particularly in seropositive patients, very big tumor factor brain lesions in the white matter. So here's a case where you can see all these three findings. You see that arch pattern here of the corpus callosum, of large, big tumor factor white matter lesions, smaller lesions in the left and the basal ganglia, and then also involvement of that right corticospinal tract. And interestingly, this was a kid, not an adult, A, and B, did not have much periependymal lesions, and then tested positive for equipotent P4 IgG NMO spectrum disorder. So just keeping in mind all the different patterns, and then knowing that, it's appropriate to give a good differential diagnosis, but knowing that these can look like that. So going into optic nerve imaging for NMOSD, is these lesions are commonly posterior, longitudinally extensive, and they often involve the optic chiasm and optic tract, and they frequently bilateral. And this is, in the middle-aged male, which usually you see NMO much more commonly on the adult side when compared to the pediatric side. We can see involvement of that optic chiasm. Now, on the spine imaging, these are longitudinally extensive transverse myelitis, again involving 3 or more vertebral segment. They're also transversely extensive. They'll often involve the entire transverse diameter of the cord, or at least more than 50%. These lesions can be located both centrally and peripherally. Typically, the more cervicothoracic spinal segment, in contradiction, where you have more involving the conus. And then sometimes you can have these little bright spotty lesions, which are defined as lesions with very high T2 hyperintense signal. And we don't know, it could be microcystic changes or necrosis or some CSF trapping along that central ependymal lining. But that also could be a clue for NMOSD or other longitudinally extensive transverse myelitis. So here's just a case showing, transversely and not like super longitudinally, but involving more than 3 vertebral segment transverse myelitis. Okay, and with that, we'll end NMO and then go into our next topic, pediatric onset multiple sclerosis. So pediatric onset multiple sclerosis, it's basically again defined as MS occurring in people under age 18, and small percentage of cases, about 3 to 10% of all MS patients occur in the pediatric population. And in peds, they are more often relapsing or remitting. CSF oligoclonal glands, these are strongly positive because there is no serum or CSF like antibody test for MS, like unlike what we saw for MOG and NMO. So I'm not going to go in detail into the McDonald criteria just because I think it's been out there for a really long time, but I did put this up here. It's from a recent article from 2023. It's a really nice updated article on pediatric MS. But I just wanted to talk a little bit about the changes that were made in the 2017 revision of the McDonald criteria. So one of the things is that the oligoclonal bands in the CSF can substitute for the requirement of demonstrating dissemination in time, enabling an MS diagnosis in a patient who meets criteria for dissemination in space on MR imaging, which means if there's an initial attack or the first attack and MR shows dissemination in space, but not in time, but if the CSF is positive for oligoclonal bands, then that substitutes that is equivalent for showing dissemination in time. So that was a change, a notable change. And then the other change was they also added cortical lesions in addition to juxtacortical lesions for consideration for dissemination in space. I think that's probably there's more research and it's not purely a white matter, it can also involve gray matter, so it kind of makes sense. So on imaging, you can see multiple ovoid, well-demarcated T2 lesions in the periventricular region. Typically on a sagittal T2 flare images, you'll see what's called the Dawson's finger. They can involve the callososeptal interface. They can be juxtacortical, cortical, infratentorial, so all your typical lesions. They are usually pretty well circumscribed, discrete, ovoid in a perivenular distribution. Multiple sclerosis, like by definition, there is dissemination in space and time. So active, how do you define that? So active demyelination, if you see lesions with restricted diffusion and enhancement, then that's important to note. If you see lesions that are T1 hypointense, like very hypointense, reflecting, T1 black holes, which basically is sort of an end stage, a more chronic process where there is sort of an irreversible axonal loss, then that's important to mention in your report. So here is a 11-year-old boy presenting with 2 days of headache, blurry vision, and clumsiness, and you have these multiple ovoid T2 lesions sort of nicely seen perpendicular to your ventricular surface. There are some lesions in the infratentorial location and bilateral middle cerebral peduncles, and then you can see the sort of incomplete enhancement, many of these lesions reflecting active demyelination. What about tumefactive MS? Sometimes you might see a mass-like lesion. It's usually single. It's pretty bulky, at least more than 2 centimeters. You won't see a lot of edema surrounding it. You'll have this sort of incomplete heterogeneous enhancement. So you can think of tumefactive MS in the appropriate setting or as a differential. Optic nerve imaging in MS is pretty different, again, when you compare it with MOG and NMO spectrum disease. So here it's more frequently monocular or unilateral. It's short segment optic neuritis without involvement of the optic nerve sheath. So you won't typically see optic perineuritis in MS. And okay, that last line is ignored. So here is a short segment optic neuritis on the right involving the intracanaliculaire segment and prechiasmatic segment. And on the spine, you can have multiple lesions. These are often short segment, preferentially posterolateral, and they tend to involve less than 1/3 of the transverse chord area. So here are some typical spine lesions in multiple sclerosis. They're well circumscribed, very short segment, and discrete, often posterolateral, kind of wedge shape. So these are not longitudinally extensive or transversely extensive as we see in MOG or NMO spectrum. So that's important to keep in mind. And then now that we've kind of looked at all these, just to do a little bit of a compare and contrast, is when you look at, all the acquired demyelinating syndromes, autoimmunity plays an important role in the pathogenesis, but they have very, different underlying mechanisms, and which is why they're all considered as distinct entities. Like if you see multiple sclerosis, your CD8 T cells are going to be more predominant. NMO spectrum is typically an astrocytopathy, where this is the astrocyte, and you can see, in this image that I took from this article, there's the equipotent P4 antigens and antibodies, they bind out in the astrocyte, and there's a lot of profound axonal loss here. While MOGAD is more of an oligodendrocytopathy, that's the oligodendrocyte, and that's where the MOG antigen antibody interact. So there are some differences, and the differences in the way they might present and the way we treat and the way it looks clinically and on imaging. So despite the fact that, there are underlying similarities with all of these being demyelinating disorders, there are many differences too that we should keep in mind. So any kind of diagnostic workup would involve like MRI, brain and orbits with and without contrast, a total spine with and without contrast, looking at cell-based assays, where you want to look at anti-MOG antibody in the serum and anti-equipotent P4 antibody in the serum. So not so much in the CSF because these are extrathecally produced. So you're looking at the serum. And then LP because oligoclonal bands for multiple sclerosis. And now in 2017, McDonald's criteria, that's also, much more important because it substitutes for dissemination in time. So if we just look at CSF, MOG-associated antibody disease will have more elevated lymphocytic pleocytosis, not so much in MS. And in NMO spectrum, you'll have more elevated neutrophils and eosinophils. So there is a little bit of a difference in the way pleocytosis plays out. And oligoclonal bands are uncommon in MOG and NMO, and they're common in MS, which we already talked about. So kind of like a little summary sheet here. When we talk about MOG, we're looking at bilateral longitudinally extensive optic neuritis, which is greater than 50% of the length, and anterior involvement, optic perineuritis, and sparing of the optic chiasm. In the brain, you can have ADEM-like pattern, cortical encephalitis, meningeal enhancement, very rarely a leukodystrophy-like pattern. In the spine, it's longitudinally extensive transverse myelitis. You can have involvement of the central, either a preferentially gray matter with an 8 sign or a gray and a white matter with a more centrally located lesion. There's involvement of the conus, and the enhancement can be seen in the choroiquina. When we come to NMO spectrum disorders, again, bilateral longitudinally extensive optic neuritis, but it's more posterior. So it involves the optic chiasm and tract. It has a predilection for involvement of the equipotent P4 rich areas in the brain, but sometimes it can also involve, like, remember, the corticospinal tract. You can have tumefactive lesions. Longitudinally extensive transverse myelitis in the spine, more cervicothoracic. It can involve the whole circumference, and sometimes you can have these little bright spots within them. For pediatric onset multiple sclerosis, the optic neuritis is usually unilateral and short segment. In the brain, these are typically discrete ovoid lesions, periventricular, juxtacortical, cortical, infratentorial. And again, in the spine, these are also a very short segment and preferentially like posterolateral cord lesions. So in conclusion, it's sort of an evolving field, right? And the diagnosis basically relies on not just what we see, but the clinical features. They need to do the lab work, the spinal fluid analysis. So it's a very collaborative effort. And we just need to know that different imaging patterns can help with suggesting, appropriate differential diagnosis. Like the take home here is like, I just want you to know that, okay, if you see something that looks like viral encephalitis, you want to think that, oh, MOG can look like that. Or if you see a pattern in the spine, oh, okay, this can, this could also look like that. Or if you're seeing sort of an atypical pattern, or could NMO spectrum look like that? So it's in keeping in the correct clinical context in adding to your differential diagnosis, right? And it's always helpful because if they test positive, then that really helps start the appropriate clinical management early, and that helps to reduce future disability for these patients. So it is important for us to update ourselves, know all the new criteria, the changes that are taking place, and because that's going to make a difference. What we say, it's going to make a difference. So I think that's sort of my talk. These are all my references. Thank you.
Thank you so much. That was great. I mean, definitely, it's such an important topic. It's something we deal with a lot, and can be very challenging sometimes. You see a lot of these lesions, whether to suggest this versus some other kind of encephalitis. It can be very challenging. So I think, yeah, this was a great overview, and some great cases. And yeah, thank you so much. That's pretty incredible. Also, like how much the field is evolving too. They're always discovering new antibodies and stuff like that. So we'll see what happens in the future. There'll be many more antibodies that they'll discover. If anybody has any questions or comments, feel free to put them in the chat. We already have a couple. So question, so for the flames pattern for MOGAD, it can mimic hypoxic ischemic injury pattern on MRI. How can we differentiate the two in imaging and expedite serum analysis for anti-MOG?
So flames pattern is going to be much more cortical based. So it's going to look like, it's going to mimic your viral encephalitis, if anything. I feel, as compared to an HI pattern, but you're also looking at the patient, the clinical context. I think if you see, my point is, if you see something where you're seeing a lot of cortical-based lesions with extra diffusion, it looks like maybe this could be viral encephalitis, maybe this could be other differentials. But putting in MOG is important because they can test it, and if they can test it and if it turns out positive, they can treat it, right? So I think that it's important to add your differential. You may not always be able to differentiate everything on imaging, but it's important to put that in. Typically, hypoxic ischemic injury is going to have more typical patterns with deep involvement or watershed involvement, just based on how the underlying ischemic injury took place. So I think there are differences in the way the pattern is going to look on imaging as well.
Thanks, I agree. Yeah, and I think I agree, especially, and then also talking to the clinical teams and who are really seeing the patients. I mean, I agree. There definitely been cases where you're not sure, and then you talk to the team. It could definitely be something infectious, just based on your imaging, and then you talk to them, and they're like, oh yeah, the patient doesn't look infected, the CSF doesn't look like it's an infectious cause, and that can kind of steer you, I guess, yeah, towards one of these other syndromes, yeah, from the infectious side. And agreed about everything you said there. Let's see. Another one, is it sufficient to give a radiological diagnosis of NMO when there's longitudinally extensive transverse myelitis, periapendymal lesions, area postrema, and bilateral prechiasmatic optic nerve segment and optic chiasm involvement, and not entertain MOGAD in these patients?
Yeah, if I see something that's so typically involving the, where all the equipment before, channels, I would put NMO much higher. But you have to remember that MRI is a supporting feature. Like, when they look at these kids, like as we talked about in the 2023 MOGAD criteria or 2015 NMO spectrum criteria, it starts off with, these core clinical features, and then they have to test for the antibody, right? So, and then we have supporting MRI features. So it all goes it all goes together. It's sometimes, I think if it's very typical, I would report as it is and say this, configuration looks more typical for an NMO spectrum disorder over MOG-associated antibody disease. And I think that's fair. But ultimately, they're going to test for the antibody to confirm it. So I think that's important, is that we are not, no matter what we write, the testing needs to take place. So.
Great. We got a comment. Thank you. Great presentation. Another a bit off topic, but have you seen cases of Guillain-Barré syndrome with mild cauda equina nerve root enhancement after years since onset?
Without any recurrence or just like asymptomatic patient after years since onset? Or is it like a recurrent?
That's the,
Oh.
I guess, but there's a polysymptomatic.
Polysymptomatic. Yeah, I've seen them like normally in an acute setting, but I do not recall seeing patients like years after onset with kind of minimal symptoms. So I think, but nothing else, no spinal cord lesions. Just isolated cord. Yeah, I don't know. Have you, Adam? I don't remember. But have you?
I'm trying to think. I don't think they get imaging if they're asymptomatic a lot of the time.
So
So maybe we're missing it, but I think yeah, if symptoms have resolved, I don't think they usually get follow-up imaging necessarily to make sure that the enhancement is resolved. As far as I can't remember any specific cases that it kind of persists without symptoms. I mean, you can have a chronic, like a CIDP, like a chronic inflammatory polyneuropathy, but without symptoms. Yeah, I mean, maybe there's not imaging. Maybe we would see it more if they image the kids more. But I can't remember anything.
Thank you.
Any other comments, questions? If not, then yeah, thank you so much. This was wonderful. And hopefully we'll see everybody next month for next month's talk.
All right, great. Thank you so much.
Okay.
Bye-bye.